Hello and a very warm welcome to this webinar about the diagnosis and the management of non-dystrophic myotonia, also known as NDM, hosted by EMG Health and sponsored by Lupin Neuroscience. My name is Professor Giovanni Meola, and I will be chairing the discussion today. I'm very pleased to announce that I'm joined by the expert in this disease, Professor Christiane Schneider-Gold and Professor Jordi Diaz-Manera, who will each be presenting today. To begin, I will give you an overview of the differential diagnosis and how to confirm NDM. Then I will be joined by Professor Jordi Diaz-Manera, who will be presenting his case study on NDMS caused by chloride ion channel defects. Professor Jordi Diaz-Manera was recently appointed Professor of Neuromuscular Disorders at the John Walton Muscular Dystrophy Research Center at Newcastle University in the UK. You will also be hearing from Professor Schneider-Gold, who is joining us from Bochum in Germany, where she leads one of the country's largest neuromuscular specialist units. She will be presenting a case study on NDM caused by sodium ion channel defects. So, without further delay, I will begin our education session starting with my presentation. This is my disclosure. So I start with the NDM classification. The NDM classification, so non-dystrophic myotonia, NDM encompass chloride channel NDM and the sodium channel NDM. The chloride channel NDM can be split in Thompson myotonia congenita and Becker myotonia congenita. The sodium channel NDM is much more complex because it encompasses sodium channel myotonia, which comprise myotonia fluctuans, myotonia permanens, both potassium sensitive and acetazolamide sensitive myotonia. There is also paramyotonia congenita and closely related some myotonic disorders like hyperkalemic periodic paralysis, which combines sometimes with the paramyotonia congenita, and severe neonatal episodic laryngospasm, also called SNEL. The NDM has a severe impact on the daily quality of life. A person with NDM has really indeed negative emotion, such as feeling restriction, persistent tiredness, worries due to unpredictability, and pain, pain and cramping. There's also a social anxiety. The patient is unable to release a handshake, sometimes difficulty in eating, and the problems in speaking. There's also lack of independence, so there is occasional support is needed when driving and need help with tasks, and also he complains locking during movements. Regarding the issue with daily living, there are challenges in dressing and also a limited manual dexterity in also stiffness, and sometimes problems in climbing stairs. So there is a reduced activity and occasional assistance is needed during driving. Some work duties can be challenging, and and sometimes there is a difficulty crossing streets. But what is very important is the general medical history. So when you suspect NDM, you should ask what are your primary symptoms: stiffness, cramps, muscle weakness, and or pain. Particularly, in which muscle do you experience the most stiffness? For example, in heads, face, and grip legs. Do you experience persistent and or episodic muscle weakness? Do you notice, this is very important, the presence of specific triggers, such cold, stress, potassium-rich food, exercise, or during menses? Did your symptoms change in intensity during pregnancy? Another important question, when did your symptoms start? Did you have the problem at birth or during childhood? Problems in breathing or feeding, episodic stridor during early childhood? Were motor milestones met on time? And you were able to perform sports during childhood? For some special issues, which I will cover later, have you experienced complications during general anesthesia? And also the family history is very informative. Do you have relatives with similar complaints? Are your parents related? And at the end, one other important point, are there any signs of multisystemic complaints as seen in myotonic dystrophy, both in type 1, both type 1, type 2, in the patients or relatives? For example, cardiac arrhythmia, sudden cardiac deaths, respiratory problems, gastrointestinal problems, ptosis, cataracts, and cognitive problems. The use of EMG. The question, can electrodiagnostic testing be used to guide the genetic testing? The answer is yes, because after clinical examination, we need to perform a needle EMG, and you can see the myotonia graph, but later during this webinar, you will see a video clip about the myotonic discharge, but are very important, the short exercise test performed at room temperature in one hand and cooling and rewarming on the contralateral hand. Professor Diaz-Manera will show a video clip. We have a 3 characteristic EMG pattern. And because we are looking to the amplitude and the area, we have the pattern 1, where you have a decrease, a concordant decrease of amplitude and area, and this decrement is more than 20%, which is much evident in the first trial, but began worse in the successive trials. And with this pattern suggests to look to screen for the sodium channel mutation, mainly for the paramyotonia congenita mutations. There is also pattern 2, where you have a concordant amplitude and area decrement more than 20%, as you can see here, but in the successive trial, you can see the return to normal value. This pattern is suggestive of chloride channel screening. But if during this test After cooling, there is a change to pattern 1, as specified before. We should look at to the paramyotonia congenital mutation. If the pattern 2 and if the chloride channel our screening is negative, we should look at for the myotonic dystrophy screening, mainly the M1 and the M2. And if this test is negative, we should look at some very rare mutation of sodium channel mimicking myotonia congenita. There is also pattern 3, where the decrement or is less of the amplitude in the area is less than 20%, or decrement not concordant. In this case, if there is a symptomatic or paradoxical area closure myotonia, we should screen for the sodium channel, especially for the sodium channel myotonia mutation. If during this test we have also a minimal area closure myotonia, but a prominent false, we should screen for chloride channel screening. But of course, if these channels are screening is negative, we should look at to the other channels, to the sodium channel, and also reversal for if the sodium channel mutation are negative, we should look at for the chloride channel. So to summarize the EMG pattern, we have pattern 1, where there is a decline in each map amplitude worsened with successive trials, correlated with the weakness induced by exercise. The pattern 2, the first exercise causes a decrease of CMAP amplitude, which returns to normal value within 20-40 seconds after exercise cessation. And the pattern 3, where no CMAP decline after repeated short exercise. What about the differential diagnosis of NDM? So this is the NDM diagnostic algorithm. If we suspect in a patient NDM, where there is a patient of the clinical myotonia without master wasting or systemic symptoms, we need to perform EMG to confirm by EMG electrical myotonia. If this is positive, we can go to the genetic testing for sodium channel and the chloride channel, and if they show if they are positive for pathogenic variant, no further testing are required. If the EMG is inconclusive, consider alternative diagnosis. So in this case, if the family history is suggestive of NDM, again, we should test genetic, we should perform genetic test for sodium channel and chloride channel. And if no variants detected, or we found VUS, variant of uncertain significance, further testing is required. So in the differential diagnosis, the genetic testing by look at the chloride channel and the sodium channel. If they show pathogenic variant, we are in presence of a definite NDM and no further testing is required. If no pathogenic variant is detected, we have a possible NDM. It's very important to perform a short exercise test and look at the electrodiagnostic features. If we should also consider the M1 and the M2 testing, and if the M testing is negative, but there is only electrical myotonia, consider acquired causes like some drugs, like agents, like diazocholesterol, or other genetic myopathies like pompe disease or myofibrillar myopathy. If we are in presence of the variable or of variant of unknown significance, consider probable NDM and consider the predicted effect of boost mutation and the conservation in the genome. But it's very important to perform some detailed genetic study like segregation analysis or in vitro analysis like some patch clamp studies, expression studies of the mutant if available, because they can help for the diagnosis. So the diagnostic criteria, there is a definite NDM where there is genetic confirmation of the sodium chloride channels, EMG showing myotonia, consistent clinical history examination. Possible NDM when there is no genetic confirmation but EMG showing myotonia and the consistent clinical history examination. Probable NDM1 when we have genetic testing for BUS, but EMG showing myotonia and the consistent clinical history examination, and probably NDM2 when there is a genetic sodium channel or chloride channel, but the EMG is atypical, like pseudomyotonia, like some complex discharges, and the clinical history examination are not informative. So the common NDM treatment options, we have some approved and unapproved NDM treatments. Just to remind that mexiletine is the only treatment for adult NDM that has a regulatory approval. Other drugs are not approved and their use is off-label. Regarding the mexiletine has been approved as an orphan drug for NDM, approved on-label use only in the European Union, but look to the safety. The side effects are GI discomfort, dizziness, tremor, ataxia. The lamotrigine approval for epilepsy, bipolar disorders, and for the NDM can be used as off-label, but there are many side effects like skin rash, headache, fatigue, nausea, severe life-threatening side effects. The acetazolamide approved for glaucoma, epilepsy, fluid retention, NDM for the NDM off-label use, but a lot of side effects, nephrolithiasis, paresthesia, rash, granulocytosis, electrolyte abnormalities, and GI discomfort. Ranolazine approved for chronic angina, off-label use, and safety for constipation, dizziness, and headache. So we have a special issue. I'm going very quickly. For the pregnancy, many women reported worsening of NDM symptoms during pregnancy, which may be exacerbated by having to stop treatment of mexiletine. There are limited amount of data, but we know that mexiletine crosses the placenta and reaches the fetus. So as a precautionary measure, it is preferable to avoid the use of mexiletine during pregnancy. Anesthetic complication. Some cardiac anesthetic may cause a myotonic crisis with severe generalized muscle stiffness. The use of muscle relaxant succinylcholine should be avoided. People with NDM should carry a medical card or wristband to warn of this risk. So my last slide, the summary. A range of NDMs are caused by defects in master sodium or chloride ion channels. NDMs can have a severe impact on patients' quality of life. Clinical history examination is suggestive of myotonia plus MG findings, and syndrome should be excluded for the differential diagnosis, and the mexiletine is only licensed for adult NDM. Many thanks for the attention. To introduce Professor Diaz-Manera. Thank you.
Thank you very much, Giovanni. Hello to everybody. I'm very happy to stay here with you and present my experience in this disease. So I'm going to present two cases of patients with clinical myotonia produced by mutations in the chloride channel. When we saw the patient for the first time, she was working as a waiter, and I remember that she complained that she was unable to open wine bottles for the public. So that was one of the problems that she had in daily living. She also referred difficulties with quick starts when sprinting or swimming, and at that moment she had the feeling that she was unable to start doing this exercise and that the stiffness increased. So clear increase in muscle size in the arms, legs, and the pectoral muscle. But despite having these very big muscles, she was weak. So we observed some mild weakness in the deltoid, biceps, and psoas muscles. So there was clear leg and arm muscle stiffness. The first steps when she was sitting were clearly slow and improved quickly after repetition. There was no clinical or percussion myotonia in hands, no lead lag, and there was no permanent or transient paresis and non-paradoxical myotonia of repetitive movements, including eyelid closure. So, based on the initial patient history and clinical presentation, which type of chloride channelopathy myotonia do you think is more likely? Okay, so 66% of you think that the patient has the Becker myotonia congenita, and 33% think that the patient is 50-50 now, so we check. Okay, that's fine. Let's keep going. So this has been excellently presented by Giovanni. I think that, remember that when we have a myotonic syndrome and paralysis, we can divide this in dystrophic, which are myotonic dystrophy type 1 and type 2, both autosomal dominant and produced by an impaired chloridium channel function. And we have non-dystrophic myotonic syndromes, and here we have two main problems, or impaired chloridium channel function or impaired sodium channel function. So we will talk later about impaired sodium channel function, but here I think that this is a nice picture because you can see where the myotonia is more severe. For example, in patients with chloride channel function, so both Becker and Thompson, you can see that myotonia is more severe in the legs, while the arms can be affected but are less affected. And this is different in patients with sodium channel function dysfunction, where you can see that it's variable depending on the clinical picture, but is in general more severe in the upper limbs and also the facial muscles. So when we suspect clavicular channelopathy, there are some clinical features that can be shared both by Thompson and Becker myotonia congenita. For example, age of onset is during the first or second decade of life. There is a decrease of myotonia after repetitive use or contraction, what is called the warm-up phenomenon. In general, patients can have pain, but pain is less prevalent than in other causes of myotonia. It's very common to have leg stiffness, and they can have hand or arm myotonia, and it's not uncommon to find transient paresis at onset of activity. But this is more common in Becker myotonia congenita. So in clinical examination, we can find sometimes myotonia in leg muscles. Myotonia will decrease with repetitive use. This is the warm-up phenomenon. And remember that we can have this transient paresis that can be present in bicep muscles. And as you will see later, there are some specific electrophysiological features. So if we suspect that we have a patient with a myotonia, we have the first thing that we have to do is confirm this myotonia using electromyography. So if we have confirmed this, so we identify myotonic discharge in electromyography, and the patient have extramuscular manifestations or persistent muscle weakness, the most common and prevalent disease is myotonic dystrophy. So I would start checking if the patient is myotonic dystrophy type 1 or the patient is a myotonic dystrophy type 2. But if we have a patient that has just myotonia, without any extramuscular manifestation and without muscle weakness, I would probably think in a non-dystrophic myotonia, and then we can have a genetic test for the chloride and sodium channels. So let's go back to our patient. So the lab values showed that the patient had mild increase in creatine kinase, but normal liver enzymes. And we performed an EMG that demonstrated the presence of diffuse myotonic discharge. With the needle, the pattern of voluntary effort was completely normal. There were no signs of myopathy using needle electromyography, and nerve conduction studies were also normal. So we have now the second question on my talk. Based on this information, so clinical and complementary test, what diagnosis can you exclude and why? Perfect. 90% of you have ruled out already myotonic dystrophy type 1. That's good. So in front of a patient that have lack of permanent paresis without any multisystemic manifestation, normal liver enzymes, even if the patient has mild increased CK value, indicates that oligosymptomatic myotonic dystrophy is unlikely. So the what is called the Fournier test. So the Fournier test is an EMG study that we use to try to distinguish between the different channelopathies. So this is a study that is performed with an EMG. In my opinion, it's very easy to do. It's not really difficult from a technical point of view, but can be long. So the main aim of the study is try to reproduce what happened in a muscle after a contraction that can be short or long, and we want to analyze the motor action potential of a nerve. Trying to close the finger. So the patient will do this during a certain period of time, and we are going to then stimulate the ulnar nerve and analyze the amplitude of the motor action potential of the ulnar nerve. So in the main protocol starts with a basal stimulation, where we are going to analyze the motor action potential at baseline. The paper described that it could be interesting to perform a repetitive stimulation now before starting the study, just to be sure that there is not any problem in the neuromuscular junction. Then we perform the short test. In the short test, we ask the patient to do that exercise that I just showed you during 10 seconds. And after the 10 seconds, we stimulate the nerve immediately after that. So this is what you see here, 2 seconds, and then at 10, 20, 30, 40, 50, and 60 seconds, so during 1 minute. And we are going to study the changes that can happen in the amplitude of the motor action potential. Any change can be either an increase or a decrease in the action potential that is higher than 20% respect to the baseline is considered significant. So in the short test, what we will see in controls is that there are no significant changes in the amplitude of the motor action potential. Is what I am showing here as B. In chloride, what we are going to see is that there is a decrease just after the exercise that can be variable, but is significant. And this action, the amplitude of the motor action potential is going to recover and come back to normality very quickly, in 10-20 seconds. You can see that the pattern is more complicated in patients with mutation in the sodium channel, that they can have very important and maintained decrease, or as you will see later, even an increase. The next step in this study is that we are going to ask the patient to repeat the short test 3 times. So we will perform the same study 3 times in a row. In the case of controls, you can see that the motor action potential is stable every time. In the case of chloride mutations in the chloride channel, we will see the first one with this immediate decrease, the second one that it's better, and the third one that recovers normality. So this means that after a while, what we are seeing here is the warm-up phenomenon. So the patient is not having the same problem with depolarization in the muscle. And you can see that the response can be different in sodium, depending on the mutation, with a persistent increase or with a persistent decrease in the action potential. And the exercise test ends up with the long test, where we are going to ask the patient to keep doing that exercise for 5 minutes. Every 35 seconds, we will ask the patient to have a relapse of just 5 seconds, but we will keep pressing and doing the exercise for 5 minutes. This can be really tiring for the patient and sometimes painful. And just after that, we are going to have a first stimulus and we will repeat the stimulus every 5 minutes for between 40 and 50 minutes. So you see now that the whole study can last for more than 1 hour. So that's the reason why I was telling you that even the study is not difficult from a technical point of view, it can be very long. In the case of chloride, what we are going to see is that the motor action potential has no significant changes in the amplitude, while this is different in sodium. So as a summary, in patients with mutations in the chloride channel, we will identify the presence of abundant myotonic discharge that characterize the clinical picture and also the electrical study. And we can identify a reduction in the first 2 or 3 stimulation of the motor action potential just after a brief exercise that then recovers normality, and there is no changes after long exercise. And if you have this combination, there is a 83% sensitivity to identify mutations in this gene. So these are the results of our patient test. So there was a decrease just after the short exercise test that improved over time, and the long test was almost normal. So based on the information provided now, will you be able to distinguish between Becker and Townsend myotonia congenita? Yes or no? So the answer is no. There are no differences in the results between one or the other. So just to compare between Townsend and Becker. So in Becker myotonia, this is a recessive disorder. It's usually more severe than Townsend. The patients can have more frequently limb myotonia than elliptic myotonia. It's not rare to find transient paresis at the start of exercise, and patients can complain of pain. In Townsend, this is a dominant disease, usually less severe than Becker, and patients can also have pain. Both are produced by mutation in the CLCN1 gene. So in our case, the clinical data ING both were highly suggestive of chloride channel myopathy. We sequenced this gene and we identified these 2 mutations that were already described in this disease and confirmed the clinical diagnosis of Becker myotonia. So I would like to explain another case just to illustrate a different story. This is a 28-year-old female from French origin that was referred to our unit for muscle pain and stiffness that started when she was a child. She had difficulties when starting to do a physical activity, such as walking or climbing, that were clearly influenced by cold and also by anxiety, and that improved if she practiced before the exercise. There was no history of muscle weakness, and in the family, there was the mother and the maternal grandfather that were affected of a similar problem. So a clear dominant inheritance pattern. So muscles were big again in these patients, especially the biceps. There was no weakness in clinical examination. There was a slowing in the first step after sitting that improved after repetition. No myotonia in hands, no leg-lag, and there was no permanent or transient paresis and no paradoxical myotonia on repetitive movements, including eye-like closure. So EMG showed diffuse myotonic discharge, blood analysis, CKs were normal in this case. We identified just one mutation, an heterozygous state that was in the CLC1 gene, and this was a mutation that has been already described linked to dominant inheritance. And this was a case that was confirmed as Townsend myotonia. So how do we treat these patients? So in general, what we are going to do is to recommend them mexiletine, that is the commercial name in UK and Germany, as you know, is NaMuscla. We will start with 1 pill per day. I recommend you to start this dose for 1 or 2 weeks. So if the patient is fine, we can just keep that dose. If the patient is not completely improved, we can increase the dose to 2 pills per day. Then again, wait for 1 or 2 weeks. After that, we can, if the patient has improved completely, keep that dose. If not, we can increase to a maximum of 3 pills per day, no more than that. And we can review the case and see there is a sufficient clinical response. In our case, in the case of Becca, the first case that I have presented, we started NaMuscla. There was no response with 1 pill. We increased the dose to 2 pills per day, and there was a clear improvement after 2 weeks. But the patient was still not happy, and we decided to push a bit more and arrive to 3 pills per day. And the patient, after 2 weeks, had a further improvement, although minor symptoms were present. We then moved to the Thompson case. We started NaMuscla 1 pill per day without a complete response. We increased to 2 pills per day, and the patient tolerated very well and was effective, and we decided to stop there. So it's important to follow up patients with cardiac evaluation. We start always before the treatment to be sure that we can prescribe the drug to the patient. In the first 48 hours of starting the treatment, or in the first 48 hours after every increase in high-risk individuals, I would recommend you to do an additional cardiac evaluation. And through the treatment, we need to monitor the heart. In patients with a cardiac abnormality, it's recommended to perform an ECG annually or at least every 2 years. In patients with cardiac abnormality or prone to such abnormalities, it's important to perform an ECG before and after dose increase, and to be sure that there is a cardiac evaluation at least annually. So just to finish, I think that it's important to report this. So our patient with Thompson, when she was 32 years old, she expressed her desire to have a child. So we talked with the team that in our hospital was doing genetic counseling, and we decided to go for an in vitro fecundation that was approved. And finally, she got pregnant. We stopped mexiletine before she started on the process. And after 4 months, there was a clear worsening of the symptoms. So at that moment, stiffness lasted all day and did not really improve with movement. Stretching was not useful. Muscle pain was present, the pain at rest, but also after exercise. She was seen by our physios that started with massages, but that worked, but were not completely effective. So when the baby was delivered, we restarted mexiletine, and there was a clear improvement of the symptoms. So just to wrap up, typical signs of chloride channel myopathy are increased muscle size and myotonia. Myotonia improves with exercise, the warm-up phenomenon. Myotonia worsens with cold and stress. And pregnancy, remember, could worsen the symptoms. Becker patients tend to have more severe symptoms than Thompson. The exercise test could guide us in the genetic diagnosis in the Sanger era. Now things have changed a lot with next generation sequencing, and mexiletine could induce a clear improvement of the myotonia symptoms. But remember that mexiletine is not approved during pregnancy. Thank you very much for your attention.
Okay. Thank you very much, Jordi, for this nice lecture, nice talk. Now, can I introduce now to Professor Christiane Schneider? Please, Christiane, start your talk. Thank you.
Thank you. Dear colleagues, I would like to introduce you into clinical myotonia and sodium channelopathies. But before, I would like to thank Lupin for inviting me and my colleagues for their very elaborated talks. We have already learned a lot on myotonic disorders. And so in the last part, I will come to the more not so very well clinically defined channelopathies, the sodium channelopathies, and I would like to start with the first slide, with my conflict of interest. And in the clinical characteristic and classification of sodium channelopathy slides, you see that the clinical clues are a little bit different from those in chloride channelopathies. There's a lower age at onset, mean about 5 years, worsening of stiffness after repetitive use and contractions, which is called paramyotonia, presence of pain, presence of face stiffness. You perhaps remember the nice picture Jordi Manera has shown with the prevalence of muscle stiffness in paramyotonia in the face and in the arms. There's episodic weakness in some forms and worsening of symptoms in the cold, in particular in paramyotonia. On examination, you may see eyelid myotonia, increasing after repetitive contractions, which is called paramyotonia because it's opposite to myotonia we see in chloride channel, and therefore it was called paramyotonia. On electrophysiology, you see long duration, about more than 2 seconds high amplitude myotonic potentials, slowly deteriorating motorcycle sound, and an interdischarge interval of myotonic potentials of less than 30 milliseconds. The Fourier pattern has already been shown with pattern 1 or 3 after short exercise testing. The sodium channel differential diagnostic pathway is shown here with sodium channel myotonia and comprising potassium sensitive forms, which is myotonia fluctuans and myotonia permanens, and the acetylcholine sensitive myotonia. Paramyotonia is clinical, I would say, the most clear form, with the classical paradoxical myotonia increasing with repetitive muscle contractions. Closely related to the SCN4A myotonic disorders are the hyperkalemic periodic paralysis, which may be accompanied by myotonia, either paramyotonia or just a myotonia after physical effort. Also, severe neonatal episodic laryngospasm is a closely related SCN4A disorder. After the clinical overview on sodium channelopathies, I will introduce a patient. It's a 34-year-old male patient. He consulted a physician after a long history of non-specific muscle cramps, reported from age years old, and he was still able to perform sports since his youth. He had some difficulties with starting, in particular with quick starts in sprint competitions, and he observed worsening of symptoms if a second running was on the same day. The first was fine, the second was not that good. There was marked muscle cramping after having running distances of more than 400 meters, and he reported no cold influence. He had observed that there were increasing muscle cramps when not having eaten for several hours. He further showed some leg muscle stiffness when rising from a chair on examination. He had some mild slowing of his first steps after sitting. He had mild grip myotonia and mild eyelid leg on first, but not on repetitive testing. And muscles appeared well trained, a little bit hypertrophic, as Professor Manera has shown in his patient, but not to that extent, like in chloride channel myotonia. After 1 hour of physical activity, he presented with strikingly more pronounced muscle stiffness, in particular of the leg muscles, with slowing of walking without showing a warm-up phenomenon for more than 5 minutes. So there were no permanent or transient paresis and no paradoxical myotonia on repetitive movements, including eyelid closure, and there was no warm-up phenomenon after physical exercise. Now, I would like to encourage to answer this question. Based on the initial patient history and clinical presentation, which type of NDM do you think is most likely? Okay, I see there's some preference for Becker myotonia congenita, but it could perhaps also be Thompson myotonia. I think the idea is not bad because in some patients with chloride channel myotonia, warm-up phenomenon may be very mild. But I will go further to give you some more details which may help to find the right diagnosis. EMG in the patient was not very conclusive. Family data suggest autosomal dominant inheritance, with the mother and aunt having noticed marked muscle cramps during pregnancy and mild muscle cramps after physical exercise and also during or after normal daily activities. A cousin also suffered from muscle cramps. And I want to stress this point. Mother and aunt had increasing muscle cramps, myotonia, after physical exercise. So there seems to happen something due to physical exercise. There was no history of multisystemic manifestations, which make the diagnosis unlikely to be DM1 or DM2. In the next slide, so the pattern on EMG on voluntary effort was normal. Nerve conduction studies were also normal. And laboratory values showed only mildly elevated creatine kinase with normal level enzymes. So I would like to ask a next question. Based on the additional information, which diagnosis can you exclude now and why? The lack of permanent paresis and of any multisystemic manifestations in context with normal liver enzymes despite a slightly elevated CK value indicates that oligosymptomatic myotonic dystrophy is unlikely. Lack of transient paresis and lack of a typical warm-up phenomenon indicates that autosomal recessive or dominant chloride channel myotonia may not be the right diagnosis. So, which diagnosis is the right one? The patient history and clinical and EMG data suggest NDM. That's clear. Lack of transient paresis and lack of a clear-cut warm-up phenomenon indicates chloride channel NDM is unlikely. Lack of paradoxical myotonia and lack of codependency, as reported by the patient, also make paramyotonia congenita less likely. The occurrence of myotonia after physical activity suggests it could be a sodium channel myotonia. The assumption, supported by a report of symptoms worsening during periods without eating, makes it likely that there is some relation to potassium levels, potassium serum levels. You all know that when you have a high sugar level after eating, potassium is lowered in the serum by a process that is directed by insulin, and in the opposite, potassium levels may increase in periods without eating. So this indicates there's a relation to the potassium level. And to go through here, with NDM as the post-diagnosis, you may suspect that it is a sodium channel neuropathy. You can perform the short exercise test as discussed before, and you may see pattern 1 or 3, but this may not really help to decide which kind of sodium channel neuropathy is present. Paramyotonia congenita has some distinct clinical features which were not present in the patient. There was no sign of hyperkalemic periodic paralysis because there were no periodic paralysis. But there was a clear-cut relation with physical exercise and probably with potassium serum level, indicating that it may be potassium-sensitive myotonia. So, given the additional case information, which sodium channel NDM do you now think is most likely? So, genetic testing and differential diagnosis for sodium channelopathies. In this patient, we had a potassium-sensitive myotonia, which was not myotonia permanens, because if this would have been present, the patient would have had symptoms right from birth on, and he would never have been able to perform sports. He had a mutation as shown here in the SCN4A gene, and this mutation was related to the potassium-sensitive myotonia, which is also named myotonia fluctuans, fluctuating myotonia depending on serum potassium levels and also physical effort and exercise. But to repeat again, paramyotonia could be excluded because of the lack of typical clinical features. Myotonia permanens could be excluded because of the history of the patient and the lack of a really severe myotonic disorder. And hyperkalemic periodic paralysis could be excluded because of the lack of periodic paralysis. The take-home message is that typical signs of sodium channel myotonia are paradoxical myotonia, if it is paramyotonia, and exercise and cold-induced myotonia. Cold-induced myotonia is also typical for paramyotonia, not for potassium-sensitive myotonia, but exercise-induced myotonia is typical for potassium-sensitive myotonia. The presence of mild myotonia at rest and increasing of myotonia during or after physical exercise, and in this patient it was the second run after first run, which was very quick, and increase of all presence of myotonia during periods without eating are typical for this type of myotonia, which is called potassium-sensitive myotonia. Myotonia in sodium channel myotonia responds to class 1B antiarrhythmic drugs, and including mexiletine, as shown in the scheme by Professor Manera before. You may also treat by other antiarrhythmic drugs, which are off-label, but may work also in some distinct mutations. So, this is the last slide, just referring to the neuromuscular prescribing information and addressing that you have some contraindications, distinct dosage and administration regime, and precautions, and you have to look for some circumstances of life in the patients, and you have also to avoid overdoses, because this may be fatal for cardiac reasons and so on. And with this slide, I would like to finish my talk. And I thank you very much for your attention.
So now we start the questions. One question. So we can start. If there is, if any of the non-dystrophic myotonia, can I have an age of onset more than 20 years? Yeah, I think that we can have some patients. We can have also some patients more than 20 years, right? Okay. Do you agree? So no problem.
Yeah.
Okay.
Also, there is a range of disease manifestation. Most patients manifesting at about 10 to 15 years in chloride channel myotonias, but it may be later in some patients with very mild myotonia. And I know a lot of female patients reporting their first myotonic symptoms, which they really notice as abnormal during their pregnancies.
Okay. So there is another question. So what would you recommend associating two drugs, such as mexiletine and lamotrigine, rather than reach the maximum level of one of the for the treatment of NDM? Well, I will answer according to my experience. In my experience, I will not recommend to associate two drugs, just to avoid some side effects. What I will try to do, for instance, for mexiletine or lamotrigine, is just to reach the maximum level, and sometime according to the experience of the patient. For instance, I have one patient with a PAM, which is potassium related to myotonia, permanent myotonia, PAM, where I gave a big dosage of mexiletine, like 6 tablets, you know. So I think that of course, according to what said Professor Manera, we should be very careful for the to monitor the cardiac status. But I think that this is my opinion. I don't know if also my colleagues agree that it is better to reach the maximum level, but I should for each drug, but I should avoid a combination of the drug, because otherwise we have a lot of side effects and it is difficult to treat the patient. Okay. Do you want to add some things, Jordi? Or?
I agree with that. I agree.
Yeah. Also you, Christiane? Okay.
I agree to that. There are only very few cases where you decide to use two drugs. This may be some side effects of mexiletine, due to some side effects of mexiletine at higher dosage, or some very subjective feelings of the patients who feel better with two drugs. So, but this shouldn't be the regular case.
Okay. So there is one question for you, Christiane. Is pain worse in sodium than in chloride?
I think this is not easy to answer just as a general statement. Pain may be very severe in paramyotonia, and I have some patients who suffer very much from pain, but there are also patients with chloride channelopathies suffering from pain. It depends on the severity of myotonia. I think there's a direct relation to the degree of myotonia. Okay.
There is a question for Professor Diaz-Manera. What are the long-term consequences of living with a disease to the NDM patients?
Okay, thank you very much for that question. I think it's very interesting. So in my case, I think that I can comment about chloride patients. So in general, we have two kinds of patients. So patients with Thompson myotonia may have just the symptoms, the typical symptom with stiffness for all their life. But it has been also described that some patients with Becker muscular dystrophy, Becker myotonia, can also develop some degree of muscle weakness, especially late in life. That is my personal experience. So the patients that I have seen, sometimes they can have a part of the stiffness. They can develop muscle weakness, especially proximal, that difficult them to climb up stairs or stand up from a chair. I have never seen a patient with a severe muscle weakness secondary to mutation in the chloride channel, but I don't know if you, Giovanni, or you, Christiane, have a different experience than me.
Yeah. Yes, I agree, Jordi. Can I make also a comment about this point? Yes, I agree with what you said. So in that case, it could be very helpful to perform an MRI, muscle MRI, just to see, because we have some patients, they complain stiffness, they complain weakness a long time, and the MRI, the muscle MRI can really tell us, can give us a lot of information, because it's possible just by MRI, where there is some paper describing that by MRI you have also different sign between chloride and also sodium, but the MRI could be really helpful, in my opinion. Yeah.
Yes, I think there are some very rare mutations in the chloride channel gene that can cause some pronounced atrophy of the distal lower arm muscles.
Yeah.
In some contractures, this type has, I think, been described by T. Ashisawa. He has described such forms, but this is very rare.
And
Okay.
Christiane, is this different in sodium? So do patients with sodium develop muscle weakness over time or not?
I think normally they don't develop muscle weakness. But for instance, in patients with hyperkalemic periodic paralysis, there may be some patients with very extensive myotonia, even leading to high CK values. And if you don't give them medication to stop this continuous activity, they may develop some weakness, some permanent weakness.
Okay. Yes. There's a question for me. What can I do while waiting for confirmation of a genetic diagnosis? Sometimes it takes too long to get the confirmation. Many thanks for this question, because this is a very interesting question, very practical question, because sometimes takes time, takes 2-3 months to have the answer from the genetic. Well, personally, according to my experience, if the genetic diagnosis takes too long, in other words, if I have a patient where there is a clear myotonia, where I have the where the EMG is confirming the myotonia, well, I will start treatment. In other words, because just to improve the quality of life, because so in some patients, I remember now, where I'm positive that this patient is affected by NDM, and I'm sure, so I will start treatment. I don't know what is the opinion of my colleagues, but anyway, I will start, because just to improve the quality of life. Okay?
Yes, I agree.
Exactly.
I think that I don't see other questions so far.
I have seen a question on the treatment with quinine, and also questions concerning the treatment with lamotrigine.
Yeah.
I know some patients who are treated with carnitine derivatives. This may work indeed, but in many countries this is not available or not allowed to take this medication regularly, because it may cause some very severe bone marrow depression. But I have some patients who are very convinced of treatment with carnitine derivatives.
Yeah, yeah.
And with the lamotrigine, I think it's good. It works in patients with mild myotonia. It may work rather well, and it has been frequently administered during the time when mexiletine was not available, and some patients still tend to take it all the time, and won't be switched to mexiletine.
Yeah, yeah. Well, of course, but there are some, there are many, some, for instance, I was just thinking, but sometimes, even is very rare, we can have some patients with some, we are epileptic, with epilepsy, and also with myotonia. So maybe they use before to be treated by carbamazepine, which can give some side effects. So maybe the lamotrigine could be more helpful, I think, because of course we should interplay with the patients.
Sure.
Okay.
And it would be a good solution in patients who also suffer from a bipolar disorder.
Also for some poilus. So I think that lamotrigine could be also a good choice, mainly when there is some comorbidity with some myotonia patients, which sometimes we see,
Exactly.
Can I ask something?
Yeah, of course.
So I have a question for the both of you that have larger experience than me. So I would like to know if you have patients with a clear picture of non-congenital myotonia, but with any mutations in any of the genes, so that you have studied all the genes associated and nothing appears, but they have a clear non-dystrophic myotonia. Do you have patients like that?
Yes.
Yeah. Sorry, you said the patient with congenital myotonia, you mean?
Yes, with non-dystrophic myotonia, but without mutations in the chloride or in the sodium, and they are not myotonic dystrophy patients. Do you have patients like that?
I have not. But listen, what I want to say, and in this case, in these patients, do we have at least the genetic is completely negative, or we have also some VUS, some polymorphism? I want to ask you, Jordi.
No, I don't have patients like that. I just was asking if you have.
Well, I can see I have some patients where I'm really convinced, patients with myotonia, with a really severe myotonia, where there is not clear mutation, both in chloride or sodium. So that they present some VUS, some polymorphism, some variant of uncertain significance. So in these patients, I suggest, I'm really convinced for the myotonia, both clinically and also electrical myotonia. So what I did is just to study the polymorphism in the to do the expression study. In other words, I don't know if it's clear, by sophisticated technique. This is research by patch clamp to do some study to look at the behavior of this mutant and in this way, it's possible. For instance, I have one patient. In this way, I have one patient with severe myotonia, with nothing, and the researcher was able to test the mexiletine in these patients, and now practically the patient is got very well by mexiletine. But I was able only by expression study, by very sophisticated techniques. We published also one.
I just have seen in the questions, a colleague has written that he asked for the percentage of patients with a typical myotonia congenita and paramyotonia congenita phenotype who lack mutations or even was in the chloride or sodium channel respectively. And he or she wrote she had a couple of patients with DM2 lacking myopathy on EMG, only showing myotonia, who had a phenotype similar to myotonia to congenita.
Yes.
Yeah. But you know, this is where we are changing a different field. You know that for DM2, Christiane, there have been described some modifier gene effects.
I know,
You know, for instance, where we showed in Milan, you know, we have some paper about it. We showed that in some DM2 where have chloride channelopathy or also sodium channelopathy, they can really modify the effect in DM2 regarding the myotonia. Yeah,
I just wanted to refer to the comment of the colleague. And there was another interesting question. The question was it for an NDM, one day there will be a genetic treatment approach as antisense oligonucleotides. What do you think?
So I think if I can answer this one, I think that we are far from that, in my opinion. So in my opinion, so it's true that we are starting the gene therapy era, and this is really exciting for all of us that dealing with neuromuscular diseases. But I think that we are far from this. So in my opinion, we need to solve many questions that are still open in these diseases, and with this approach to be able to consider this kind of treatment for diseases that have I wouldn't say a lower impact, but I think that we cannot compare the burden of these diseases with the burden of, for example, a patient with Duchenne muscular dystrophy. Right? So I think that we are starting with that other ones, and if we are able to provide the cure using those strategies, probably in the future we will see if everything improves and it's easier, we can also handle these non-dystrophic myotonias. But at the moment, I think that we are very far from that.
Yeah, can I make can I add a comment on this point? I agree with Jordi that we are very far from the you know, like oligonucleotide. What I think that could be helpful in this kind in the NDM will be what is called now personalized medicine. In other words, I think that it could be interesting to investigate some specific drug just by expression study. For instance, we know from the literature that some patients it's possible, you know, to look at to this study. I was thinking about to the famous paper by Lehmann-Horn, no, Frank Lehmann-Horn, you know, just where, for instance, you can test some drug like mexiletine, like in our patients, or maybe, for instance, another drug which could be helpful is the flecainide. The flecainide, because there are some mutation who will respond well to flecainide, but you need to show by this expression study in vitro study by patch clamp to look at, but these are sophisticated techniques, which can give us some answer regarding a specific treatment.
Yeah.
So it seems that we have to finish and wrap up, is what we have been informed. So Giovanni, would you like to finish the discussion and wrap up?
Yeah. Well, first of all, I think that it was a very good webinar, and I wanted to thank the Lupin, of course, but also my colleagues, the different experts in this very exciting topic of the channelopathy, of the master channelopathy like NDM, non-dystrophic myotonia. So thank you to everybody. Okay. And many thanks indeed.